Good evening, everyone. My name is Dr. Jodie Guest. I'm an infectious disease epidemiologist and professor and vice chair of the Department of Epidemiology at Rollins School of Public Health here at Emory University. I lead Emory's COVID-19 outbreak response team working in harder hit communities across the state of Georgia to provide vaccinations and testing. I'm also the host for Emory's COVID-19 Facebook Live events, where we cover important topics about COVID-19 pandemic. Today, I'm very pleased to be joined by Dr. Alex Truong. Dr. Truong is an assistant professor of medicine in the Division of Pulmonary Allergy, Critical Care, and Sleep Medicine at Emory University. His research centers on long-term outcomes in survivors of critical illness, and he is the co-director of the Emory Executive Park Post-COVID-19 Clinic. Welcome, Dr. Truong, and thank you so much for joining me this evening.
Thank you so much for having me. It's a pleasure being here.
Absolutely. I'm really excited about our topic tonight. We're going to be talking about long COVID-19, something we've not talked about yet on any of these videos that we do. But first, I'm going to go over the latest COVID-19 numbers for September 30th. The US has had now more than 43 million cases of COVID-19. Thankfully, for the past 2 weeks, the numbers of new cases has been falling. Still, we are averaging more than 106,000 new cases a day, primarily in the unvaccinated population still. While 97% of counties in the United States are areas of high or substantial transmission, new COVID-19 cases remain highest in several specific states. Cases continue to be the highest in Alaska, with a case rate that is double that of the next highest rate of any state and 6 times higher than the rate for the United States. The states with the next highest case rates are Wyoming, Montana, Idaho, North Dakota, and West Virginia. We are approaching 700,000 deaths in the United States from COVID-19 and are averaging close to 1,500 deaths a day still. 12 to 17-year-olds continue to have our highest case rate, followed by 18 to 39-year-olds and 5 to 11-year-olds. New hospitalizations are down across the United States this week by 14%, but we still have more than 85,000 people in the hospital with COVID-19 and 8,500 people being admitted each day with COVID-19. The US has vaccinated more than 214 million people with at least 1 dose of COVID-19 vaccine, and 56% of the US population is now fully vaccinated. While most of the data for the past 2 weeks is showing that we are seeing decreasing rates of cases, hospitalizations, and deaths from COVID-19, our conversation today is really relevant to all 43 million people who've already experienced COVID-19. It is estimated that up to 1/3 of COVID-19 cases may result in long-term illness. So in the United States, this means we are potentially talking about 14 million people who may be enduring or have already endured consequences of the illness for months or years to come. So we're starting to get some insights into the lingering disorder that affects some people infected with COVID-19, but there's still much to learn, and we're going to have this conversation with Dr. Truong today. So Dr. Truong, let's begin by talking about what do we mean when we say long COVID? You know, it's still being studied, there's still a lot of research, we know some numbers, but really what do we mean by this term?
I think long COVID has actually been puzzling for patients because part of it has to do with the fact that we have so many names for it. It's also known as long haul syndrome. It's also known as PASC, post-acute SARS-CoV infection syndrome, as well as long COVID. It's usually seen in patients who have had an acute COVID infection, has recovered from that acute infection, and about 4 to 6 weeks after that infection, they still have lingering symptoms that are affecting their daily lives. This can be anywhere from brain fog to chronic pain to shortness of breath to memory loss and confusion.
So as we talk about, I know that there are a cascade of symptoms that could fall into this category. What are some of the most common symptoms that you're seeing? And does it change from people who have symptoms for a couple of weeks after COVID-19 to those who have really persistent symptoms longer term?
I think the most common thing that we actually see is fatigue and brain fog. I think a lot of our patients are saying that they have to sleep excessively. They can't survive a day without a nap, or they're sleeping 12 to 14 hours, whereas opposed normally would sleep somewhere between 6 to 8 hours. Additionally, they're having significant memory loss, brain fog, where they have difficulties finding words, losing track of sentences in the middle of conversations, as well as trying to organize their activities of daily living or their jobs. So that's been really affecting them as well. Other things that we've been seeing commonly in our patients is a lot of shortness of breath. And frustratingly, the shortness of breath doesn't seem to be only because of just lung pathology. It seems to be related to maybe fast heartbeat syndromes. It may be related to the fact that they're having just overall fatigue that's making them feel very short of breath. That's been challenging for us to treat. As for if it's changing, a lot of our patients actually kind of evolve in the symptom presentation depending on how long out it's been since their infection. Obviously, the more common things that we've seen early in the infection include cough, chest pain, and chest discomfort associated with acute infection. But as the disease progresses, things like the shortness of breath takes over, the brain fog takes over, the chronic fatigue kind of takes over.
So most of our original data about COVID-19 and long COVID comes from people who are hospitalized. And so that's not a particularly representative sample. I'm curious what you've seen, because hospital data show about 87% of people may have really persistent symptoms after they are discharged from the hospital. Are you seeing that? Or are you seeing people who also had COVID-19 that did not require hospitalization?
Well, if we look at our population, about 50% of our population are actually patients who've never entered the hospital, who had their diagnosis of COVID and were told to isolate at home. They may have seen the primary care doctor, but never had to spend a night at the hospital. And then the other 50% are patients who've been hospitalized. And in that population, about a third in the ICU, 2/3 on the hospital floor. So I actually think that COVID-19 long haul syndrome or long COVID actually is affecting a lot of patients who seem to have what we term as mild disease that never brought them to the hospital.
So other things that I've seen that show some differences, trying to get to, who might be most at risk for this thing that we're still trying to learn how to fully define, right? What about differences in age? Are you seeing any differences, and can kids get this?
Unfortunately, I'm not seeing that many differences in age. It seems that all over the board as to who's getting it. And in our clinic population, the average age of our patients are approximately 50 years old. So in medical terms, that's actually not very old. We do have a handful of patients who are 18 years old, which is the youngest population that we see here. However, I do get a lot of phone calls of patients who want to be seen who are anywhere from 14 to 17 years old. And unfortunately, how our clinic is run, I try to send those off to pediatrics. I think that it's hitting all over the board. There's definitely patients who are older as well as patients who are younger. So in my population, I think my oldest patient is 90 years old, who has lingering symptoms from their from their COVID infection.
But it would be a misnomer for us to think that children, where we tend to see less significant symptoms with COVID-19, they are still at risk for getting long COVID.
Definitely. But we don't know if there's any protection that children have at all from having it. So what we are seeing is it is affecting everybody across the board. So I do think that the risk is definitely there.
It's hard when we can't necessarily pinpoint who's going to be most at risk for something.
Right.
Getting to the reason that we are seeing these longer term complications with COVID-19, most studies seem to show that the virus does clear your system after just a few weeks. So what is the hypothesis for why we see longer term symptoms in some people?
I think that's $1 million question. I think if we can answer that, we can help so many people. We actually have been doing some research here, and in our group here at Emory, we've actually just recently pre-published a paper that seems to suggest that these patients are having autoimmunity, meaning that they have residual antibodies that the bodies have produced, and that their body's reaction to that antibody is actually causing some of the perpetuation of these symptoms. In my population, there was an initial thought that it was related to inflammation or residual inflammation from the infection. But when I look at my group of patients and look at their inflammatory markers, the ones that we tend to follow for COVID, D-dimers, fibrinogen, ESR, and CRP, there doesn't seem to be a correlation between how severe or how long your disease lasts and how persistent those inflammatory markers are. So I don't think that that's actually going to play out.
It's going to be interesting to follow the science and where it goes on that particular, explanation for why we might be seeing these persistent symptoms. I think it's fair to say that the most protective thing you can do to not get long COVID-19 is to make sure you do not get COVID-19. And the best way to go about doing that is to wear your mask when you're in public and around unvaccinated and vaccinated people right now with the Delta variant, and to make sure that you are vaccinated. So what are your thoughts on vaccination being protective for long COVID?
I think you hit the nail on the head right there. I think if you don't want to get long COVID, then you shouldn't get COVID, or at least try not to get COVID. And I think the best way to do that is exactly what you said. I think that the vaccine will help in terms of preventing you from having the COVID infection that leads to long COVID symptoms. I think that there's been a lot of misinformation and social media perpetuated falsehoods about the vaccine, but I feel like it's safe and it's very effective. And in my patient population, it's been shown to be helpful in keeping them from getting the illnesses, the severe illnesses that land them in the hospital or in the ICU.
Which is really what we're working so very hard to make sure does not happen. Let's turn to the clinic that you helped start and that you co-direct at this point in time. Long COVID has become now recognized as a public health problem. And in January, the World Health Organization revised its guidelines for COVID-19 treatment to include recommendation that all patients should have access to follow-up care in case of having symptoms of long COVID. So you started this clinic. Tell me how you went about doing that and what was the impetus for you to get this started?
So this clinic actually started in August of 2020. So we were actually early on, and Dr. Abid Dixit was one of my colleagues who actually started the clinic. It initially began with the thought that we had a lot of patients who are coming through our ICU and our hospitals who are very sick with COVID. And at that time, once they were discharged, the question was what was happening with them and did they have any follow-up care that was needed. I'll be honest, at that time, I don't think that we were as cognizant about the impact of long COVID as we are now. And so the initial thought was the clinic was to help develop a resource for these patients to come through to help manage the anticoagulation that they were on because of blood clots they may have had during the hospitalization, or to help continue their pulmonary recovery after they've been on the breathing machine or mechanical ventilation. So we started again the clinic in August of last year, and as we start seeing more patients, we were seeing a lot more outpatients, patients who had never been in the hospital before, coming with this whole slew of symptoms that were consistent with the long haul or long COVID syndrome. And so our clinic kind of changed to help adapt to that population. For example, we are screening patients more for memory loss and brain fog than we were initially, because we didn't see that that was a huge thing when we first started the clinic, but as it evolved, we saw that that's much more of an impact. We have incorporated a lot of subspecialists into our group to help us, including psychology, neuropsychology, neurology, physical therapy, cardiology, rheumatology, to name a few. So I think it's taken a whole group of us to help figure out how to take care of these patients.
With a wide-ranging host of potential symptoms associated with long COVID, I can see why you would need a large group of people to help and support. So how does one go about getting an appointment, to come see you? And what is that first appointment like? Is it to figure out what path they need for support? And does that change over time for a patient as they are with you?
Yes. So to get an appointment with us, they would need to call the Emory operator and ask for an appointment with the post-COVID clinic. Unfortunately, we are pretty jammed with patients now. With every wave of COVID infection, there is also a wave of post-COVID syndrome patients. And so unfortunately, we're booked out until I believe November. But if there's an emergency or any a special needs, I can always squeeze patients in addition. Our first clinic visit tends to be pretty long with these patients. It is to get down a whole history of what happened during the initial infection, possibly how they got infected, how the disease progressed, what medications or therapies they received for their acute infection. And then since their infection, what symptoms have they been struggling with now? We take a long history, we do a thorough exam, and then depending on what their symptom presentation is, we lay down a plan on how to help these patients. Often what that includes is referral to neuropsychology to help kind of better tease out exactly what the nature of the brain fog or memory loss is, possibly referrals to other specialists if there's cardiac or rheumatologic issues that need to be addressed. And then we also do a standardized testing on them to look at what the level of their brain fog is using the Montreal Cognitive Assessment Scale, which is a short attention and memory test that we administer, as well as there are questionnaires about what their symptoms are and screens for things like anxiety, depression, cognitive decline, as well as fatigue.
Very good. As it made me think, as you talked about the very first appointment they have and talking about their treatment with COVID-19, does monoclonal antibody have any role in this in protecting people from some symptoms of long COVID, or are you seeing people who've had it coming into your clinic?
So every patient that comes in, we ask what treatment they've received. And I would say I see less monoclonal antibody treated patients than I do remdesivir, steroids, and the others. So there may be a signal there, but again, our clinic isn't set up to be able to answer that question. Mm-hmm. And I think definitely more research is going to need to be done to see if your initial therapies change the outcomes of what your long haul symptoms are.
That makes sense. Sticking with treatments, once you enter into a long COVID therapy program with you, what kind of treatments are available to support people as they, as they learn to live with these symptoms and hopefully progress to beyond these symptoms and improving and getting back to some level of normalcy before they had COVID-19?
I think that's a really challenging question to answer because it's almost a evolution in process right now to try to figure out how to take care of patients. I think with every week that goes by, we learn a lot more. Again, it also depends on exactly what symptoms they're struggling with. We have found that overall, in all COVID patients, there's a small number of patients that seem to have a response to antihistamines because there's a belief that there is a mast cell activation syndrome that these patients have, and that the use of antihistamines, whether it's Allegra or Zyrtec, in addition to a histamine blocker for the stomach like Pepcid or Zantac, has been shown to help those patients with their fatigue, their memory loss, and sometimes their shortness of breath for some reason. We unfortunately are having a hard time trying to figure out which of those populations are going to be benefited from those medications and which are not. And according to our lab work, I can't seem to find a signal that would make this patient more likely to benefit than not. For the memory loss and brain fog issue, we are quickly evolving in our understanding of that. And I'm actually super excited about this. We have been working with Dr. Michelle Haddett of neuropsychology to try to help figure out exactly what the nature of the brain fog is. And there seems to be a signal that in addition to a memory issue, there seems to be a concentration or overactivation of the brain issue, so that these patients are overly distracted maybe, and so that the memory isn't sticking in. That also seems to have implications on their ability to organize things, to process things, to plan for things. So in that population, use of stimulants for such as medications used in ADHD, Ritalin, Strattera, and sometimes the medication Provigil has actually been shown to help some of these patients clear the memory loss, and as a side effect, also help them with their fatigue. That's still a process that we're learning about. That's still a process we're still trying to evaluate on a more systematic basis. But we are gathering the data for that to see if that is the actual signal that's worth chasing after. Lastly, we actually have patients who have shortness of breath. And that shortness of breath can fall in two major categories. One, shortness of breath from lung inflammation and scarring that's actually residual from COVID pneumonia itself. And those populations of patients seem to be responsive to steroids that are used for over weeks to months. There's a more puzzling second category of patients with shortness of breath that seems to have shortness of breath related to either airway inflammation, fast heart rate, or just some idiopathic shortness of breath that we can't seem to figure out after exhaustive testing. Those patients sometimes respond very, very well to inhaled steroids. Some of those patients respond very well to medications that slow down the heart rate, like beta blockers. So it really depends on what your symptoms are.
You guys are really taking on some very challenging medicine without a lot of information and learning as you're going, as one does in a pandemic. But still, I'm impressed and yet overwhelmed listening to the myriad of things that you need to be taking care of.
Yeah, it definitely takes me out of my comfort zone. I'm trained in pulmonary critical care medicine, and I can't remember the last time I ordered a stimulant or an antidepressant. But I think these patients definitely have a very wide spectrum of symptoms, and I think that unfortunately there's not that many of us who are actually comfortable taking care of that huge spectrum of issues. So it has been an interesting challenge to address.
Well, it sounds like one that's very needed. And, so on behalf of Emory and all the patients that you're seeing, I thank you for starting this. I've been doing some research in preparation to speaking with you about long COVID. I did read that there are some support groups that are forming on social media and other places. Have you, has Emory started a support group like that for people who are suffering from long COVID, or have you heard conversations about how important that might be?
To be honest with you, I don't know if Emory has started a support group, but I do know that there is a handful of support groups out there. I think the worst thing about the post-COVID syndrome that we're seeing is that a lot of patients are feeling alone. I think they're feeling very isolated. They feel like their healthcare professionals or physicians are telling them that it's either in their head or they'll just get better on their own, or that they can't do anything about it. And I think it leaves these patients feeling very disconnected and lost. And so I think these support groups are super, super helpful in helping patients not only find a community to empathize with them and what they're going through, as well as sharing resources, talking to each other about what may work and what's not worked. They've actually passed physician names around. I know my name, unfortunately, has been mentioned a handful of times in these groups, and that's how I've met some of my patients. I think that that there's a good resource in these groups for these patients. I would also, on the other hand, warn about taking everything that's posted on these groups as gospel. I think sometimes they also act as fertile grounds for patients to spread misinformation or not intentionally, but information about things that may not work, like medications like ivermectin or these over-the-counter holistic medications that may cost patients a lot of money.
I think we have all seen the positives that can happen with our connections on the internet and social media, and certainly the pandemic has helped us see where there are some problems with that as well. Dr. Truong, as we wrap up here today, is there anything else that you would like to share with us about long COVID or your clinic and this experience that you are having walking through this, caring for people who really need you while you're learning as you go as well?
I think that there's a lot of people who are affected, not only by the physical aspects of long COVID, but also the mental aspects of it. I think that it's caused a lot of anxiety and depression, and I think a lot of patients are just suffering alone, or they feel like they aren't understood or somehow thought to be made guilty for making it up or whatnot. I think that if I can share with my patients that they aren't alone, that it is real, and that there are some resources out there that may be able to help them. Still understanding that a lot of this is a work in progress, and we're still trying really hard to figure out how to take care of patients. But I want them to know that there are resources out there, that they are not alone, and that what they're going through is real.
I think acknowledgement is probably incredibly important for people to hear, and recognizing how common it is.
Right.
I was really surprised when I started reading some of the research about how prevalent long COVID symptoms really might be for, such a large portion of people who've had COVID-19.
Right. And that number is just growing and growing, unfortunately. And that doesn't even include the patients who aren't telling us that they have it, or the patients who are at home suffering by themselves.
Right. Well, your clinic, a real gem for Emory, and what we're doing to support everyone as we work to get through this pandemic. So I will just end by saying this is just the beginning of what scientists are learning about the insights of this lingering disorder that affects some people who are infected with COVID-19. Lots of mysteries remain, but Dr. Truong, you and your group are doing such important work to both acknowledge, support, care for, and learn as you're going with people who really, really need your support right now. So for those of you watching, thank you for watching us today. Remember, the safest way to protect yourself and those you love from COVID-19 and long COVID-19 is to get vaccinated if you've not done so yet, and to remember to continue to wear your mask while you're indoors in public spaces. And we thank you all for watching. Dr. Truong, thank you again so very much.